everyone. My name is Miran Chen, and I'm a pediatric rehabilitation medicine physician in Children's National Hospital. I had the privilege to work with our wonderful interdisciplinary leukodystrophy team at Children's National and to care for families and patients with LCC. And I thank you for having me today, and I apologize I couldn't be with you in person today. I would have loved to see you, but I'm happy to be able to communicate through this virtual platform. And today I'm going to address one of the most common questions families ask. What equipment does my child need? And I like to show how we think about mobility equipment in rehabilitation medicine and how to give you some practical tools to help advocate for your loved ones. Today we will review various mobility devices and what we consider and how to maximize each equipment and when to consider changes and talk about what's new. Take a moment and think about what you see in this picture. Many people immediately notice a wheelchair or a brace. As a rehabilitation physician, I see something different. I see possibility. I see a child going to school. I see time spent with friends. I see participating in sports. One important thing to understand is that mobility is not yes or no question. It's not simply, can you walk or can you not walk? There's a whole spectrum in between, and our job is to find each person the right tools for where they are today and augment their possibilities for participation. I'm going to give an example of one category of equipment in a walker. And when people generally hear the word walker, you might often imagine one thing, maybe the gray one, or maybe rollator. In reality, there are many different types of walker and gait trainers. Some are designed mainly for balance, some provide trunk support, some are designed for endurance, some are used primarily for therapeutic walking, some are better in all terrains, and that's why mobility equipment is never one size fits all. Family often ask, how do you decide what equipment is best? And this is a really important question. Once you have the equipment, you are likely to be with the equipment for 3 to 5 years per insurance guidelines. For pediatric and adult, typically 5 years. And the answer to this question is, it really depends and it really on many different things. We think about goals, we think about current abilities and how it's projecting. We think about strength, movement, muscle tone, endurance, cognition, pain. We think about environment, and best equipment recommendation depends on much on the home and school as it does on the child. I think this may be one of the most important slides in this entire presentation. Before we start talking about equipment, we need to start with goals. What matters most to you, to your family? Getting around the house, going to school, playing with friends, conserving energy, something for a medical appointment, maintaining good sitting posture, taking steps for exercise purposes or for bone health? The answer will be different for every family, and often the goals will change over time. Yes, and I also wish there was an equipment that addresses all of these, because that's what I would want for my patients and families, but unfortunately we're not there yet. One of the important concepts that we need to discuss is the trade-off, pros and cons. There's always trade-offs. For example, lighter equipment is often easier to transport, but it doesn't give you as much support. More support equipment is often larger and heavier. A stroller may be convenient, but wheelchair offers more positioning options and independence. There's rarely a perfect piece of equipment that does everything. Instead, we're trying to find the best balance for each individual situation. So when we're evaluating someone, we spend a lot of time asking questions. Are abilities improving, staying stable, or becoming more difficult? Are we having falls? Do we have any pain? How is the energy level? How is joint looking, are we having any contractures that impacting the gait or discomfort? What activities are becoming harder? And importantly, what's working well and what's not working well? Understanding the barriers and facilitators also through history tells us an important piece. And importantly, we come up with things that we can make improvements on. Can we decrease a barrier? And can we augment the facilitator? Next, we'll look at what a person can do today. Can they sit independently? If you're sitting, how much support do you need? How is the positioning looking? Are there signs of scoliosis? Are there any skin breakdowns? Any pain? How about standing? How does that look? Is that with one hand standing? Are we standing only with the orthotics? Or are we able to stand briefly independently? How are we looking? Taking steps? How much support do they need? Do they need one hand, two hand to use the equipment? How about vision? Any impairment in vision? How about cognition and mood, preferences, personalities? All of these factors influence equipment recommendations. But we will also consider, what could this look like in 3 to 5 years? I'd like to give an example. This is an 8-year-old child with LCC. He started walking around 2.5 years old, so slightly delayed gross motorly, but he is ambulating by himself. But unfortunately now experiencing a little bit more falls and fatigue. Keeping up with friends is becoming difficult. The family lives on the 3rd floor of an apartment building without an elevator. He enjoys video games and spending time with friends. What would you recommend? And this is exactly how rehabilitation medicine works. We don't start with equipment, we start with getting to know you and looking at the whole picture. So, all my families know that you need to bring your orthotics and equipment as much as you can, because that's an integral part of the assessment. As we look at this boy's orthotics, supramalleolar orthotics, abbreviated as SMO, which is mostly used for pronation, gotten too small. As you can see right here, the line is far below the 5th metatarsal bone right here. And obviously this is not an 8-year-old foot, but please don't mind the non-matching age for the pictures. And you're noticing that over time, the pronation has gotten worse. Pronation is where the ankles are rolling, and the contractures. And this is where we don't know, chicken or egg situation. Are we pronating more because the tendons has gotten tighter, or are the tendon getting tighter causing more pronation? And we honor him liking video games, but there's really not a lot of physical activities, and home is not really accessible with 3rd floor, no elevator. So we recommend physical therapy to start stretching the ankles, strengthening the legs and core, gait training to work on balance and endurance. We add on a nighttime stretching brace to improve the ankle contracture, and change the orthotics to ankle foot orthotics to give a little bit more support, and walker with the seat for longer distance, because going up and down, carrying the wheelchair up and down 3rd floor is not a good option. Doing an adaptive stroller could work with the transportation of the equipment piece, but he is social and he wants the independence. He does not want to rely on anybody else to be pushed around, so those are not a really good option. So we recommend a walker with a seat so that he can take a break. And given that he is not exercising as much, we recommend an exercise program where he is to go on daily walks for 15 minutes every day and improve a minute a week to improve on endurance. Maybe we suggest for him to play Pokemon Go, catch 5 Pokemons, whatever we need to get him more motivated to exercise. Here's another example. This is a 12-year-old with LCC, has significant motor impairment has slowly progressed, and limited communication. He needs assistance with transfer and is not really independently walking in the community. He does have an adaptive stroller, but that's 5 years old and getting more uncomfortable. He's also having difficulty with head control, especially in the booster seat. He is having frequent foot positioning that is causing discomfort and bruises with the current stroller as well. The family lifestyle is pretty active. They do have frequent medical appointments. They go to park, family events, eating out, and they're looking for equipment that is easy to transport in their vehicle while providing adequate positioning and support. So we talk about the options. His cognition allow him to follow one-step commands. He can answer yes and no with ASC, which he can't really use as much because he doesn't have a way to don it on his stroller. He is social and going through puberty. We know what that means. And he likes color blue. So we come up with these two options. Although he has been in a stroller for a long time, this is a time where we need to consider changing it to the wheelchair because he's needing a little bit more head support. So for positioning purposes, and wheelchairs will allow you to be able to mount a communication device a little bit more easier. Also, although transportation may be not as easy, adaptive stroller at age 12 will still be pretty heavy, and you may still want to do the pros of having more support would be more important than ability to transfer, as long as it can fit in the chair. We talk about power chair because his cognition is intact to be operating in addition to different mobility abilities, but the family is not able to afford adaptive van, which unfortunately in majority of the states is not covered by insurances. So we go with the manual wheelchair versus power chair for the transportation piece. And this is also another point where details can really matter. And when you are looking at him sitting, you're noticing scissoring. And when you look at the foot positioning, the foot is turning in and the foot strap is not there. And as you can see, there's so many different options for foot placement, and this is where all these details add up to provide the most comfortable wheelchair option. And I often see this happening too, where we put lots of pillows, and a few pillows are reasonable, but if I see a patient basically sitting on all side cushion, that's a sign that we need to look into a different option for the wheelchair. Adaptive car seat is one of the tougher one as well, but there are some rule of thumbs. Generally, it's recommended that you use commercial car seats, restrain whenever you're possible, because it's easy access, it's crash tested. You do rear facing as long as possible with the limit of weight and height of each car seat. So look through the weight and height limitations. And some of the car seat has a little bit more support than the other, so look for those as well. And always know that what comes with the car seat is generally crash tested, so they are safe. But whatever you buy in Amazon or off the shelf, you need to make sure they're crash tested, because if it's not, it actually could be more harmful in an accident injury. Some of the adaptive car seats are available. As you can see, this is for a child who has difficulty sitting. It has a better head support, the buckle, and the seat elevation piece, and maybe a tray. So those are an option, but usually many of the state will approve adaptive car seats, usually after age 8 and after you have trialed commercial car seat and it's no longer supporting. And these are car seats for a little older kids. This is an easy unvest, which is oftentimes used in school bus for support. So these are some of the considerations. And I think for 12-year-old, this type of car seat could be a good option to give him a little bit more support, and use, as you can see, as a little hip pommel here to improve the scissoring sitting. So as a family living with patients with LCC, what can you do? As much as you can, try things out before. When you are buying a new car or, any stroller, you want to try out as much as you can. And yes, you can get info from your friends, but it's not one size fits all, so you need to try things out. Try to fold it, unfold it. Just imagine if this is something that you feel you can do. If not, and if you don't have option, do the training or get used to donning on and off the transport or the medical equipment for transportation, and just put yourself um, through the patient's day to day. Imagine waking up. How will the transport from bed to the chair look like? Where are we going to put the chair or the walker? How are we going to get down the stairs to get to the first floor? Are we going to put the wheelchair on the first floor? Are we going to keep it on the second floor? All those details will matter, because what you don't want is spend all this time, wait 5 to 6 months for the equipment to come to you, and it doesn't work out. And importantly, note to advocate. You may want to ask for a letter for landlord to remove the carpet because it's creating too much resistance. As local environmental engineers, to make house more accessible, maybe school support, maybe you need an aide to help with the stroller mobility, maybe make sure the physical therapist is checking in, and maybe have a daily mobility schedule in school. And to your medical team, bring up any issues or questions you may have, and we may not always have the answer right away, but we can brainstorm with you. And again, not one size fits all. This is one of the key principles that I adhere by as a rehabilitation doctor. What has worked for one patient may not work for another, and it really needs to be individualized, and you need to know the big picture, all the details, to come up with the best equipment recommendation. This is a quick summary slide of what we have talked about and what we will consider in some of the options, but obviously it's a little bit more complicated than what we have that we can summarize in one table. So to summarize, I want to emphasize that we start with a question about the patient and family, not the equipment. We work on things that we can improve upon through rehabilitation measures and maybe more research support. Maybe we resume therapy, we work on different goals with physical therapy. Maybe we add an occupational therapy to work on hand control, hand strength, so we can use the walker. And we look at orthotics. Everything is augmenting as a equipment together. And environmental changes if appropriate. Again, if it's become a barrier. Try out the equipment options as much as you can if possible. And know that you will likely have to modify, and don't rely on just a rehabilitation technician, because what you are seeing, what you're experiencing, is one of the most important pieces, figuring out the best equipment option for the patient.